Let's finish up renal physiology with a discussion about acid-base physiology. Now, what is the normal pH of blood? The normal is 7.4, and this is a number that's very carefully regulated by the body. The main buffering system in the blood is bicarbonate. Any excess acid in the blood can combine with bicarbonate to produce CO2 and water, and this keeps the pH relatively constant. In the same way, any excess base in the blood can be neutralized with a hydrogen ion formed when CO2 and water produce bicarbonate and a hydrogen ion, and this keeps the pH relatively constant as well. So even though there are a number of other buffers, the bicarbonate system is the most important. So let's look at some of the changes that can occur with the different acidoses and alkaloses. In metabolic acidosis, we know that the pH is decreased because it's an acidosis. And because it's metabolic, we know that the bicarbonate will be decreased. Therefore, the PCO2 will also be decreased due to hyperventilation, and this is the compensatory response, hyperventilation. In metabolic alkalosis, we know that the pH will be increased. Because it's metabolic, we know that the bicarbonate will be increased. Therefore, what will happen to the PCO2? It's going to be increased due to compensatory hypoventilation. In respiratory acidosis, the pH will be decreased because it's an acidosis. So what will that mean the PCO2 will be? The PCO2 will be increased because the higher concentration of carbon dioxide is producing acid in the blood. Therefore, the kidneys will respond by increasing bicarbonate production as compensation. So we see that the compensation will be increased renal bicarbonate production. Now, let's finish up with respiratory alkalosis. In this case, the pH will be increased. Now, what does that mean the PCO2 will be? The PCO2 will be decreased because all that CO2 is being blown off during maybe hyperventilation to cause the pH to be decreased. And the kidneys will respond by decreasing the bicarbonate production. So the compensatory response is decreased renal bicarbonate production. Now for the exam, you should be familiar with the concept behind the Henderson-Hasselbalch equation, and this equation just relates the concentration of bicarb, carbonic acid, and carbon dioxide to pH. But I like to think of it very simply as pH is equal to bicarbonate concentration divided by PCO2. And if the bicarbonate goes up, then you know the pH goes up. And if the PCO2 goes up, then you know the pH goes down, because the carbon dioxide will form hydrogen ions. So you might say, but hey, wait a minute, doesn't carbon dioxide, when it reacts with water, also form bicarbonate, which is a base? Yes, it does. But remember that pH is a measure of hydrogen ion concentration and not bicarbonate concentration. So that's why CO2, even though it's producing a hydrogen ion and a bicarbonate ion, it is reducing the pH if the PCO2 increases. Now let's quickly review some terminology. Something that ends in osis acidosis refers to a process that tends to shift the pH in a certain direction. For example, an acidosis is any process that tends to make the pH lower, and an alkalosis is any process that tends to make the pH higher. However, those words don't directly refer to the pH of the blood, since there can be multiple processes that exist at the same time. In other words, just because you know someone has an acidotic process occurring, this doesn't necessarily mean that they have an acidemia. Another useful distinction is metabolic versus respiratory. Metabolic versus respiratory. Respiratory processes are those that are caused by changes in CO2 ventilation, whereas metabolic processes involve changes independent of the lungs. So before we go through the specific causes of the acidoses and alkaloses, remember that a metabolic acidosis has low bicarbonate as the primary disturbance, and this causes hyperventilation to get rid of CO2 as compensation. And the reverse of this is a metabolic alkalosis that has high bicarbonate as the primary disturbance, and this causes hypoventilation to hold on to CO2 as a compensation. In the case of any primary metabolic disorder, the predicted PCO2 value that would be expected, if the PCO2 is compensating appropriately, should be equal to the last two digits of the pH. So let me show you what I mean by that. For example, if the pH is equal to, say, 7.57, then the appropriate respiratory compensation should be a PCO2 of 57. For the respiratory conditions, the compensatory response happens in the kidney, which can increase or decrease the amount of bicarbonate that is reabsorbed. One important point is that metabolic compensation in this way takes about 24 to 48 hours, whereas respiratory compensation by a change in breathing can happen immediately. Now here's one more shortcut that you can use to identify whether a disturbance is primarily respiratory or metabolic. If pH and PCO2 are both moving in the same direction, say they're both increasing, then the disturbance is metabolic. Or it could be that they are both decreasing, but it has to be in the same direction. But if they are moving in opposite directions, say that one is going up and the other is going down, pH, PCO2, then we know that there is a respiratory process occurring. And this works only whenever there is just one primary process occurring, just one respiratory process or one metabolic process. Now let's go through some of the causes of acidosis and alkalosis. We start by looking at the arterial pH. Let's say that we have an acidemia, meaning that the pH is less than 7.4. Now what will be some of the causes of acidemia? If the PCO2 is greater than 40, then we know that this is at least a respiratory acidosis. And this will be caused by anything that causes hypoventilation, such as acute lung disease, chronic lung disease, opioids, sedatives, or weakening of the respiratory muscles. Now, what if the PCO2 is less than 40? Then we know that the acidemia is caused by a metabolic process and respiratory compensation is happening. We then want to check the anion gap, which is the sodium concentration minus the chloride plus bicarbonate. Now, what should a normal anion gap be? The normal gap is between 8 and 12. So normally between 8 and 12 milliequivalents per liter. This tells us if there are any foreign anions in the patient's blood, because these foreign anions are acids that have donated their hydrogen ions to the blood. Causes of an increased anion gap metabolic acidosis can be remembered with the mnemonic mud piles. This stands for methanol, which creates formic acid, uremia, diabetic ketoacidosis, propylene glycol, iron tablets or INH, lactic acidosis, and ethylene glycol, which forms oxalic acid, and finally salicylates, which can form or cause metabolic acidosis later after ingestion. If the patient, say, has a normal anion gap but still has a metabolic acidosis, then the causes of this can be remembered with the mnemonic hard backside, you could say. And this stands for hyperalimentation, Addison's disease, renal tubular acidosis, diarrhea, acetazolamide, which is a carbonic anhydrase inhibitor, spironolactone, which is an aldosterone antagonist, and saline infusion. Now, why does diarrhea cause a normal anion gap acidosis? Since both sodium and bicarbonate are lost in the stool during diarrhea, the anion gap equation shows that the anion gap would not change since bicarbonate is being lost, so it's going down, but sodium is also being lost, so they're both going down. And as long as they both go down equally, the anion gap is going to remain normal, and the patient will have an acidosis because they're losing bicarbonate. Now let's look at the causes of alkalosis. If the PCO2 is less than 40, then what type of alkalosis is this? It's a respiratory alkalosis, which will be caused by hyperventilation and thus blowing off lots of CO2. This can be caused by hyperventilation at high altitudes or even during a pulmonary embolism, where the patient will increase ventilation to increase oxygen saturation, but reduce PCO2 in the process. Salicylates can also cause hyperventilation because they increase the respiratory drive. And how about if the PCO2 is greater than 40? This means there is a metabolic alkalosis with respiratory compensation. And metabolic alkalosis results in the increase of plasma bicarbonate, and it's usually associated with dehydration. The dehydration is needed in order to maintain the high bicarbonate levels, because a normally hydrated person can excrete large amounts of bicarbonate very quickly. Causes of metabolic alkalosis include vomiting, which results in the loss of hydrochloric acid, hyperaldosteronism, which causes increased hydrogen ion secretion in the collecting tubule, and metabolic alkalosis can also be caused by loop diuretics and antacid use, which increase hydrogen ion excretion. Now let's work through a quick problem. Say a patient comes in with morphine overdose. You check his arterial blood gas, and his pH is equal to 7.25 with a PCO2 of 60. In order to figure out what type of acid-base disturbance this is, let's follow the algorithm. First, look at the pH. Since it's less than 7.4, then this is an acidemia. Now that we know it's an acidemia, we have to figure out if it's metabolic or respiratory. Since CO2 functions like an acid, a high CO2 level would point to a respiratory acidosis as the primary disturbance. And this patient's PCO2 is 60, so it's high. And if you look down the list, you see opioids. And that makes sense because opioids are a cause of respiratory acidosis when a patient overdoses and hypoventilates. Now, using the shortcut we mentioned earlier, a pH of 7.25 is lower than the normal pH, and when we look at the PCO2, it's 60, which is higher than the normal PCO2. So here the PCO2 has risen and the pH has dropped, and they're going in opposite directions, and therefore we know there's a primary respiratory disturbance. Now let's try a mini case. A 65-year-old alcoholic presents to the ED unconscious. When you talk to his wife, you find out that he drank wood alcohol, aka methanol, because he ran out of vodka. What would you expect his blood, pH, bicarbonate, CO2, and anion gap to be? So in order to know how to answer this question, we need to recognize that methanol causes a metabolic acidosis because it gets converted to formic acid by the liver. And this means that the patient would have an acidemia, meaning the pH would be less than 7.4, and a low bicarbonate, since metabolic acidosis is caused by a lowered bicarbonate, and low PCO2 due to hyperventilation as respiratory compensation, and lastly, an increased anion gap, since formic acid will produce formate, which is a foreign anion.